So thank you very much for inviting me to speak at this meeting. And I'm going to talk about gene therapy in haemophilia.
Hello. Hello.
Hello.
John, welcome. Just 1 minute. You would like to, Dr. John Pasi is Professor of Hemostasis and Thrombosis at the Royal London Hospital. Also, his Barts and London School of Medicine and Dentistry and Hemophilia Center Director. His research interests cover many aspects of inherited and acquired bleeding and clotting disorders, especially in new bioengineered and novel therapies for hemophilia, including gene therapy and RNA interference technology. Without further ado, Dr. John is going to talk today about current and future gene therapy in hemophilia. Dr. John.
Thank you very much. And sorry about the slight hiccup with the slides here. So thank you very much again for asking me to talk about haemophilia and gene therapy. When we think about treatment of haemophilia today, we recognize it's very good treatment, but it is a treatment that comes with a significant treatment burden. If we're going to treat patients effectively with factor concentrates, we have to give injections every alternate day. With new treatments, such as emicizumab, the treatments might only be once a week or once a fortnight, but that's still quite a significant burden for patients to think about. Hence, for many, many years, gene therapy for haemophilia has been regarded as the holy grail, the treatment that could really offer a complete change and potentially a cure for the disease. So why is haemophilia such an ideal target for gene therapy? Well, this slide lists some of the reasons. It's a single gene disorder where there is a clear cause and effect relationship. And as I've just covered on the previous slides, treatment is demanding at very best, with frequent injections for extended half-life therapies, and even the newer treatments requiring at least once weekly intravenous or subcutaneous administration. But from a scientific point of view, perhaps more importantly, there is a very wide therapeutic window. We only need a low level of expression to dramatically improve outcome. That, at the end of the day, is the basis of prophylaxis that we use at the moment to get a target above 1% to stop spontaneous bleeding. And anything above that we would welcome, obviously up to a point because there is a thrombosis risk, but we never really thought we would have to consider those sort of levels in the past. So very wide therapeutic window. In terms of assessing the treatment, it's easy. In clinical terms, patients will stop bleeding, their treatment requirement will drop, and in laboratory terms, it's similarly straightforward in that we can measure factor levels. So when we think about haemophilia therapy, we base everything essentially on raising the factor level. If we can raise the factor level, we will reduce the bleeding rate. Reducing the bleeding rate reduces the treatment requirement. Reducing the treatment requirement reduces the burden, and these in turn reduce anxiety and so improve quality of life for our patients. So how can we do gene therapy for haemophilia? Well, the ideal is to be able to give a single intravenous injection that transduces cells in vivo. That would be our ideal approach. We have had in the past historic systems that have used an ex vivo approach, much like the sickle cell approach, where tissues are removed, modified ex vivo, and then transplanted back. Over the years, lots of different viruses, vectors, and systems have been used, with retroviruses being used, with systems using different viruses to transduce cells, but we've now focused essentially on the in vivo approach. And we have used, for the in vivo approach, essentially small viruses, the adeno-associated virus, and this has become the favored approach. And this is what I will talk about most in this talk. One thing that I think is worth bearing in mind, though, is that there has been a lot of excitement, a lot of hope and expectation about haemophilia gene therapy. And we see here something called the Gartner hype cycle, which is about the introduction of technologies and the actual plateau of productivity, and how things change in between with inflated expectations, disillusionment because of technical failures, and then a slope of enlightenment as we learn what the issues are. The technological trigger for haemophilia gene therapy was in the 1990s, and the peak of inflated expectations was probably around the 2000s, and hence the trough of disillusionment in the mid-2000s. And from about 2005 to 2011, people really began to understand what the scientific issues and technical issues in terms of gene therapy were behind the problems that we were facing. We hope we are today on that plateau of productivity, but I think it's still important to bear in mind that we may be still having some inflated expectations about what gene therapy can achieve. The other thing to mention about adeno-associated virus, which I've mentioned is now the favored approach, is that the genes that we transfer through AAV do not integrate into the host genome. The lentiviruses and retroviruses will integrate. Adenoviruses, and particularly in our case, adeno-associated viruses, remain episomal. This means that the expression is deemed to be moderately stable because the episomes may be eliminated from cells upon cell division or anything that could stress the cell. So this is something that's important and may account for some of the features that we see in terms of gene therapy in the future. So what do we know about AAV, which, as I mentioned, has become the favored approach? Why is it favored? Well, it's a very simple virus that doesn't cause any pathology in man. It has two genes which can be replaced by our chosen gene cassette with inverted terminal repeats on either side. There are also many, many different types of AAV around, different serotypes, but the ones that are used in gene therapy tend to cluster in two groups. There's a group based around AAV2 and AAV8 with some work on AAV6 and 10. And there's another group of work being done on AAV5, which, although an AAV, is rather distantly related to the other clusters of AAV serotypes and more closely related to the primordial AAV, AAV-Eve. Aside from having the variations and different options for AAV, we can also modify the expression cassette to try and enhance what we want to achieve. Now, clearly, our cDNA in the main will be factor 8 or factor 9, but we can use a wild type, or we can use an enhanced gene structure, such as the Padua for factor 9, where the Padua variant, a single nucleotide change in the factor 9 gene, has 6 to 8 times the activity of the equivalent wild type protein. Both factor 8 and factor 9 are codon optimized, and additional enhancing sequences can be added. We can also look at modifying the 5' end with promoters and different regulatory sequences, and similarly the 3' non-coding elements. This is much more possible for factor 9 than factor 8. And the reason it's not possible for factor 8 is that factor 8 is such a big gene in mRNA terms to get it into an AAV that we don't have any room to make such amendments. So factor 9s can be much more altered and the cassette designed more specifically. Today, though, gene therapy has become, for haemophilia, a very crowded field. Rather than having one or two different programs out there, one for haemophilia A, say a couple for haemophilia B, we now have many, many programs. And I'm going to talk about just a handful of these selected programs, but it's fair to say that this is increasingly crowded now as a technical and scientific area of research. The real issue, though, with gene therapy is that with two of the pivotal earlier studies that were published in the end of 2017 in the New England Journal, the question has arisen, is gene therapy finally here for haemophilia? And the fact that that was probably added to by the editorial suggesting that a cure for haemophilia was actually within reach. These two studies represented one on haemophilia B and one on Haemophilia A, and I'll talk about them as we go through. But this result set was certainly very important in changing our perception of haemophilia gene therapy and what it could or could not potentially achieve. Suffice to say, for all the studies I'm going to talk about going forward, in terms of clinical impact, they all look much the same. This data is actually data from a factor 8 program using an AAV5 with a B domain deleted factor 8 from biomarin called BMN270. And what we can see here in 2 different cohorts is pre-infusion bleed rates being sort of high, and then as soon as they have the gene therapy, it plummets and becomes very low. This is because as soon as you express factor 8 or factor 9 at levels that are probably more than about 3 or 4%, the bleed rates drop dramatically, as does the requirement for exogenous therapy to be given. So I'm not really going to talk about efficacy much in this program because they all look the same. Pretty much all the data that you would present in terms of bleed rates in the programs looks like this. Now, let's have a look at these different programs, and I'm going to split them up into Haemophilia A and Haemophilia B and note some of the differences between the two and why Haemophilia A might be biologically quite different from Haemophilia B, apart from simply being a different gene. This slide shows the products in development, or the ones that have been terminated in the Haemophilia B space. And as you can see, there are really quite a lot. I'm going to talk about 3 of them, which are the Unicure program, the Pfizer Spark program, and also just touch on the data that we have from these. So the first of the important programs is the Spark data. This is a bioengineered AAV capsid containing the Padua variant. As you remember, the Padua variant has the increased activity of factor 9 compared to the wild type. This is the data that was originally published in 2017. And the reason that this data stood out was because the level of expression of factor 9 was so much higher than previous programs, which is expressed in the range of 2 to 6%. And here we were seeing means of around about 30% factor 9 at a year. That was a huge difference to what had been achieved before. And as we can see, we have a mean of around 30. What's happened over the years? Because this program is now more than 4 years out. And what we can see is that the factor 9 levels have remained essentially pretty stable over this period, as shown in this box and whisker plot. And as you can also see, the ABRs just above the graph have all remained similarly low. The other program I'm going to talk about is the Unicure program, which is based on an AAV5 serotype of AAV with both a wild type and a Padua variant factor 9. The top panel here shows the original human factor 9 wild type in AAV5 for patients that have now been followed out to 5 years. This data was just presented recently at ASH. And what you can see is, though the levels are not that high, they are remarkably stable. The bottom panel shows the same AAV, the same cassette, with one single exception, that this contains the Padua variant. This is only 3 patients. This was the original phase 2b, but what you can see is that the levels are dramatically higher, 6-fold higher in many cases than the wild type factor 9. This Padua variant has gone forward into a phase 3 program, which has similarly just reported its week 26 data at the ASH meeting. And the important thing here is that this has demonstrated very similar results. That is a mean factor 9 at week 26 of around 36%. And we can see that 1 or 2 patients that have gone out to 12 months or indeed 18 months show similarly stable levels. So together, we're optimistic about the future for Haemophilia B showing good levels that are stable for up to 5 years or beyond from the data that is available. So what about haemophilia A? I've already alluded to the fact that this may be somewhat different, and indeed it probably is. The number of programs for haemophilia A are again manyfold, some in preclinical, some in early phase 1, but the three that I'm going to talk about are the BioMarin program, Sangamo Pfizer, and also I'm going to talk about the Spark Roche program. This is the data at 4 years from the BioMarin BMN 270 study. As you remember, I mentioned this when I showed the efficacy data earlier, and this is an AAV5 containing a B domain deleted factor 8. The big difference here that you can see, apart from the higher levels at year 1, is that there is a shallow and continuous decline as we go out further. We didn't see this in haemophilia B. So in haemophilia A, there appears to be a decline slowly over years. But what we still see at 4 years, where the levels are mean of around 24 or median of 16, is still very effective bleed control with bleed rates of a median of 0. So even though they're declining, they're still providing massive clinical impact. This product, which is called valoctocogene roxaparvovec, has now gone into a phase 3 study, and this early phase 3 data was presented at the JP Morgan Investors Conference and shows that at 6 months, in 134 patients, 112 in the rollover and 70 and a smaller number in a direct analysis population, we see that again there is good expression of factor 8, but a very wide range of levels being expressed. And if we look at the panel on the right, which takes patients out to approximately 2 years, we can see that there is again some evidence of the decline, but the decline in this population is shallower than in the original phase 1/2 program. So what about other programs? This is SB525, which is the Sangamo program using an AAV6. This is the highest dose cohort. And again, we see good expression, but we also see suggestions of a decline as we go towards 12 months. And if we look at the individual plots, we can again clearly see that some patients are declining in factor 8 level. Finally, the Spark program. This data is presented in a much more scattered manner and has been through the way it's been presented at various meetings. So it's a little bit more difficult to judge what's going on, also because there are different programs of using steroids proactively, retrospectively or not. And so it's harder to see what's happening, but there is a suggestion also here, there may be something of a decline, although that this is, others might suggest that this is more stable. So haemophilia B and haemophilia A look somewhat different in terms of stability. But what can we say about gene therapy overall? Well, in terms of efficacy, it's very potent. If you express the transgene, you vastly reduce ABR and treatment reduction. There are liver function abnormalities and transient elevations of ALT that are seen across all programs, and I'll touch on that in a moment. And there might be a decline of transgene activity. So what are the recurring questions that we tend to see in gene therapy? Serotypes for AAV are very important because this has potentially a big impact on redosing and also eligibility. Patients are largely excluded if they have pre-existing antibodies. We also don't know whether the AAV serotype affects the immune response and it's a cause of the transaminitis or not. As I've mentioned, transaminitis is very common in gene therapy. With AAV, we think that one potential mechanism is a CTL response to transfected cells, but another may be the fact that we could get an unfolded protein response. So when we use steroids, are we using it as an immunosuppressant, or are we potentially using it as an anti-inflammatory agent to reduce that unfolded protein impact? We also, across all these programs, I think you will see that we've seen considerable variability in the level of factor 8 and factor 9. And are we changing our attitudes by striving to get normal levels in all our patients? How long is adequate for the treatment of with gene therapy? Haemophilia A and B are probably not the same. Haemophilia B looks more stable. Haemophilia A maybe has a decline, but how long is that that durability does it need to be to become clinically important? There are possible different explanations for decline, including failure of transgene stabilization in the episomes, transgene silencing, as I've mentioned, protein synthesis triggering ER stress in an unfolded protein response, or a persistent immune response. And we could think about the gene copy number going down or the RNA from the transgene changing. The problem is they all look very similar. And even if we did serial liver biopsies, we probably wouldn't be able to pick a difference between these different mechanisms. Finally, these AAV treatments can only be used in adults because in children with the liver growing, cells turning over, liver volumes changing, plasma volumes changing, the impact of AAV and the potential loss of the episomes would be way more impactful. We don't understand comorbidities yet in terms of using AAV, whether it's safe to use in patients with, say, HIV, or indeed more recently, HCV now might become an issue. A significant number of patients have also had a history of an inhibitor, and we don't know whether gene therapy is applicable for this group. We have undoubtedly made huge strides in gene therapy in recent times, and we have always focused on safety first, as safety must be paramount in this. But as many of you are aware, some of the safety issues have come back to the fore again very recently, with the uniQure's Haemophilia B program being placed on hold because of the identification of one of the patients having hepatocellular carcinoma. This is uncertain as to why this patient got HCV. They have had it resected, but it is one of those issues that we've always thought about. What is the oncological risk with gene therapy? HCC can indeed occur in relation to AAV gene therapy. There are mouse models where high doses of AAV are associated with HCC occurring in mice as they age. But this has been associated with the use of non-tissue specific promoters, and enhancer elements can improve this, as can giving a lower dose of AAV. But perhaps most importantly, age administration is critical. Adult mice do not seem to carry the same risk as neonatal mice. And this may well be because AAV has a propensity to integrate at the site of double-stranded breaks, which would occur in high turnover rates or where we get DNA damage or DNA stress. We are looking at this as a field, and AAV long-term issues in terms of expression has become very important and is being considerably researched. But there are a number of AAV studies out there to date, 3,000 or more patients, and the safety of it is largely thought to be reassuring. But we have to think about it. Finally, to say gene therapy today is version 1. It's a bit like an old phone, but we did see the development of the mobile phone through to the future, and gene therapy will inevitably develop and move forward and become more technologically advanced and can address some of these issues. So that leaves us with a number of aspirations for the future. That is a gene therapy that won't be affected by immunity, cell turnover, can be used in all ages, is not going to be limited by comorbidities, and can importantly be redosed and dosed to a desired level. We're striving inevitably for the best. At the moment, we've got good, but I don't think that we can say that we're not going to get better and we're not going to get ultimately the best. The next generation is maybe different viruses, maybe non-viral systems, but certainly there will be another generation of gene therapy. And AAV is today's gene therapy for haemophilia. It isn't necessarily tomorrow's. So finally, to say this is a really exciting field, but there is a lot more to come. Thank you.